do the question after the fun. So if we want to stay here on, the next speaker is Dr. Holmes, managing complication in LAA exclusion procedure, thrombus, perforation, device embolization.
Thanks. That was a great talk that we just heard, and we've had a great session this morning. If I could have my slides on. Oh, good. So I do have this relationship related to the fact that Mayo and I have a financial interest in some of the technology related to this. That's an important thing for you to realize. This is a wonderful slide about complications, and so I'm going to talk to you about two specific complication cases. I have a zillion complications. When you've gotten to be my age, I have a zillion complications. These two did not happen to be mine, but I've had worse ones, so you just need to realize that. So this is a wonderful slide from a wonderful article from 2000, the European Journal of Cardiothoracic Surgery, that it describes our most lethal human attachment. And if you're a surgeon, this is what you would write about, and this is what it is. Happens to be the left atrial appendage. That has been described as the most lethal human attachment. Can I have the slide, the sound on? This is a wonderful video of complications. Can we have audio? As you do these procedures, you're indeed going to see complications. And so as we speak then about complication patterns, it's terribly important to remember that they do exist. As we think about complications, we need to, number one, try to prevent them by anticipating the potential complications based upon either your personal experience or learning from more experienced operators. Coming to a course like this and talking about complications, seeing what other people have happened in their careers is a terribly important point. You need to hear about live cases and watch those, and then read the literature in terms of pericarditis, how you're going to approach that. We can prevent it by patient selection, by simulator experience, or by team training. After the fact, then, you need to make sure that you've had pre-planning. So that's part of teamwork strategies, is to make sure that there is pre-planning, and then have a plan B. A plan B is essential to have. You've started out with plan A, doesn't work. Plan B. You need to have in your mind what plan B is going to be. You need to have rapid access to complication management equipment. If, for example, you are doing this in a catheterization laboratory that is dealing with PCI most of the time, and they've not done pericardial access before, and there's a problem with that, you need to make sure that you have the people around to take care of that. Terribly important. Similarly, if you are working in an electrophysiologic laboratory and you happen to occlude the coronary artery just because you get in the wrong place, you need to have somebody that then can immediately do that rather than wander down the hall, look for a piece of equipment that could take care of the problem. And so you need to have rapid access to equipment that's available. These are some of the complications that we will talk about, or we could talk about, in terms of access, in terms of the device, and we've heard about that. In terms of post-procedure, and we've heard about that. And we will talk about that and these specific complications over the next day. We have seen wonderful images. This is one of the images that we need to keep in mind. We've seen wonderful CT images, wonderful echocardiographic images. This sort of image of the real deal is a terribly important one to keep in mind. And as you then think about transeptal approaches, you can think about why and where complication patterns might indeed come from, whether that be the dome of the left atrium, or if you're too high, as has been mentioned, or whether you're too low and get someplace where you did not want to be, for sure. As we think about then the fossa, this is the data that's available on what it looks like, how big it is, the horizontal diameter, and the mean thickness. Now, if you take someone who has had multiple ablations for atrial fibrillation, that mean thickness is no longer the mean thickness that it was if they had never been treated before. And so you need to have access to technology such as radiofrequency devices to get through a very tough intraatrial septum. And then we've talked about ICE guidance, and we won't talk further about that other than to say that it is essential. What are the problems? Could be unusual cardiac anatomy, rotation, or large left atrial size. You mentioned the fact that large left atrial size looks like it should be easy. The problem is if you have a huge left atrium, you don't know whether you're supposed to be anterior or posterior unless you have IVUS there, and so you can be in the wrong place. I've been in the wrong place. Atrial septum, whether it be thickened or fibrotic, equipment issues, the specific type of catheterization used, the adjunctive therapy, what to do with anticoagulants. Are you going to stop it ahead of time? Are you going to be concerned about thrombus developing in the sheath? Are you going to take them to the laboratory on heparin if you're trying to bridge them? With some of the newer anticoagulant agents where they say they should be bridged, you're going to have to take them to the catheterization laboratory on heparin. And then you have this specific approach with radiofrequency energy. You need to know about this. You need to have access to it. Your interventional cardiologist won't have a clue probably about that. Electrophysiologists deal with that. They'll know about these things. You need to have access to that in your laboratory in that setting. These are some of the complications. You can have perforation of the roof or the posterior wall or left atrial appendage itself. After each complication, it is terribly important to do a root cause analysis. Find out why it happened so you can prevent it, so you can learn about it. If you just say, well, it's another complication, and don't ever learn about it, then you won't be able to prevent the next one from happening. I specifically had an interesting complication recently, just within the last week, where we had used it was a terribly difficult transeptal. It was a patient that had a patch for ASD a long time ago. It's a very thick septum. We then had trouble getting in. We did radiofrequency. We got into the left atrium. We then put in an inaway wire, and the inaway wire then went out laterally and then down into what we thought was the left ventricle. Indeed, it had gone into the aorta, turned around in the aorta, went down, crossed the aortic valve into the left ventricle. Nothing happened because we hadn't put the dilator in, but it was certainly a rich emotional experience, I can tell you that. So this is the first case. Not my case, but this is an interesting case. It's an old case from 1985, 73-year-old woman who had mild aortic stenosis and coronary disease, came with dyspnea. Echo showed that she had severe coronary artery disease, and she was referred for cardiac catheterization in 1985. These were the findings. We were still doing green dye. Many of you in the room wouldn't have a clue what that is other than a Halloween costume. Well, we did that in the past. And this is what was performed. A transeptal was performed. The patient was given nitro. We typically wouldn't do that now, but we gave nitro because things didn't look like they were going well, and then we gave atropine after things clearly weren't going well. Hypotension, ventricular fibrillation, immediate echo was performed, and pericardiocentesis, and there wasn't any effusion. Isn't that interesting? Hypotension, ventricular fibrillation, this was before the days of ice. This patient then became no longer a patient, but a specimen. And this was what was found. 1985, and you can see what has happened. And what then has happened? What would the pathologist have found in that setting? This is what they found. Number one, she had three-vessel disease, and she died then following and during cardiac catheterization, following an attempt at atrial transeptal approach. At autopsy, one of the two catheter tracts perforated the right atrial free wall and was associated not only with aortic root hemorrhage, but with an acute intramedial coronary dissection involving the left main, the proximal LAD, and the circumflex. And so she then had acute infarction related to the transeptal catheterization. Very interesting. Now, would we recognize that today? We clearly would. The left ventricle would have gone to pot. We would have then done coronary angiography. We would have identified that. We would have treated it and stented it. We didn't know that at the time. If we didn't know that and learn from that at the time, then in the future, if that indeed does happen, then we'll know how to deal with that. The next case is another case that I did not do. I have done cases like that. It comes from Horst Sievert, and it's just a great image, probably one of the nicer images that I've ever seen. And this relates to reason for returning it. You're in the hardware store and you've done a procedure. This then is foreign body removal. As we think about foreign body removal with left atrial appendage occlusion devices, in general that wouldn't be a lariat approach, but it might be an Amplatzer, it might be Coherix, it might be a Watchman device. This happens to be a Watchman device. Let's talk just a little bit about prevention and then talk about treatment in terms of foreign body removal, realizing that these are the real deal. A foreign body removal is a real big deal because these are real big devices. How often did it happen? In PROTECT AF, device embolization, and this was reported about a year ago, that the 0.6%, 3 of 542 patients, one was intraprocedural, device embolized to the left ventricular outflow tract and required surgery. 2 were recognized later. 1 was asymptomatic, both in the descending aorta. 1 was removed percutaneously with a snare, and 1 was removed surgically at 23 months. You might say, well, does it ever happen with anything else? Data from more than a year ago. This happened to be with the Amplatzer device. We can see that embolization here also was about 1%. So we are going to see embolization of these devices, and we're going to have to deal with that and be prepared to deal with that. What are the potential factors? We've heard about the fact that we might underestimate the device size needed. And we saw a great lecture just now about the fact that you needed to oversize these devices. Otherwise, they go someplace you don't want them to go. Positioning it too proximal or tilting with a canted shoulder. And we saw a great image of that in the first session this morning, the specific left atrial appendage anatomy, and we saw great images with CT. So this is all fit together in terms of the material that has been presented. What are the things as we think about left atrial appendage occlusion devices and device embolization? Typically, it will not embolize to the carotids. It's too big. Not going to have a huge stroke. Typically, that would be the case. It can become trapped in the mitral apparatus. Typically, however, it goes to the abdominal aorta. The things that you need to have available and know how to work with. Know where to find them. They should be close. The one that we rely on the most would be an Amplatzer snare, which is a hugely important device to become familiar with. As you think about the potential for that, there are a couple of things you need to do. If you have a device that embolizes, the very first thing you're going to do is to upsize the arterial sheath. You're going to go to an 18 French sheath. If you're going to try to get it out, it has to be big enough to get it out through that sheath. You're going to have to then identify the optimal imaging plane angulation, snare retrieval, and then gentle traction. This is the case of Horst Sievert, Watchman device here, and you can see it's placed in the left atrial appendage there. Let's go to the next slide. Another angle of that, looking at residual compression, and you can see this. And then as we look here, we can see that the device hopefully is going to move and it's going to be in a good position and is going to be stable. Now do a tug test on it, and you can see the device here with a tug test. At 87 degrees, it is very stable. You can see a contrast injection at that point in time. 45 degrees, it is very stable. Take a look at that. Goodness sakes, you're talking trouble when you see that. Isn't that a great image? Goodness sakes. So at that point in time, then, you need to have plan B for sure. This is plan B in spades. This is what Horst did. He found out exactly where it was. He found the right angle to see it and increased his fluoro exposure so he could see it. That's a problem. If you get a heavy-set patient, it can be hard to find out where it is. He then used an 18 French sheath, and he was able to grasp it at that point in time, and you can see it being then withdrawn. And then you can get back to work and put in the right size and put it in appropriately at that point in time after you've finished changing your scrubs and all the other things that you do at that point in time. So what then could we talk about? Level with me, Colonel. What kind of worst-case scenario are we talking about here? There are a whole bunch of worst-case scenarios to talk about. As we think about this specific worst-case scenario, avoid panic. It does happen. Most of the time, it's not going to go to the carotids. Have to find out where it went and then decide how to take care of it. Going to want to maximize the radiographic imaging. You're going to want to identify the device orientation. Did it go upside down? Was it right side up? That makes a terrible amount of difference in terms of grabbing it, whether you're going to grab it from above and pull it out or grab it from below and pull it out. Terribly important. Or whether you're going to try to move it around into a position that you can take it out from below, because that's much better from the size of the artery involved. And then finally, Plan B is a really, really good thing to have. You're going to see complications. We all see complications. You need to analyze them after the fact. Decide how you could have done it differently, how you should have done it differently, how you would do it differently in the future. But have Plan B as part of your left atrial appendage occlusion program and setup. Thank you.